Okay, thank you very much for introducing myself. First of all, I would like to thank to here, especially, to invite me in delivering, for the role of digital health for universal health coverage financing in Indonesia, especially BPJS case. So, of course, first of all, again, I would like to thank to Mr. Alvin Marcelo, Pak Anis Fuad, and all the, um, working council team, which is, I saw it, extraordinary people, and all the participants from various countries. I would like to thank, and again, approximately 30 minutes or 40 minutes, I would like to present. Then after that, we can discuss about how the role of digital health for universal health coverage financing in Indonesia. Okay, so now I start. JKN is National Health Insurance Program in Indonesia, pillar and ecosystem. Actually, when we are talking about financing, at least there are three component important things. First component is revenue collection. This is about how to collect the revenue, the money from, of course, how many population is our coverage, then method of finance. So in Indonesia, the method of finance, there are at least three things. First, for those who poor, like in Thailand and many countries, was paid by the government. But for those who are not poor, those who has salary or those who are working in various type of the jobs, they have to pay 1% of the employees and 4% of the employer. That is number one, revenue collection. Number two, risk pooling. So it is the level of fragmentation. In Indonesia, we only have one type of scheme, which is in national level. So the risk pool is pooled in national. Then, of course, composition of risk pool, that we assess it. And then number three, the most important is strategic purchasing. It is the way we strategically purchase health services from primary healthcare, also from hospitals or referral systems. So here we will talk about benefit package, provider payment mechanism. We use what we call it performance-based capitation, and for the hospital, the way we pay is based on we call it INA DRG, or diagnosis related group Indonesian case-based. And then administrative should be efficient. So now in Indonesia, for the administrative cost is around less than 4%. And we use optimal use of resources here, including budget execution, is one of the key issues in health financing. And of course, we are thankful to God that in Indonesia, when we compare to the Lancet publication, that for Germany to achieve 85% of the population, when we are talking revenue collection, need about 127 years. In Belgium, to achieve 100% of the population coverage, need 118 years. Then Japan, 36 years, and the fastest is the South Korea, need 12 years. And we thank to God that Indonesia, within 10 years, we can achieve more than 98% of our population, or we already achieved 279.471679 members of our population. So almost 99% of all the population. And also previously, in the year 2014, when BPJS Kesehatan was established at the first time, then only less than 1,400 hospital contracted to the BPJS Kesehatan, or we call it National Health Insurance Agencies. Now, more than 3,132 referral care facilities working together with BPJS Kesehatan, and also more than 23,000 primary care physician or a clinic, or maybe we call it puskesmas or primary healthcare centers. So here, the system business model of BPJS Kesehatan in Indonesia. First, the function of the BPJS Kesehatan to collect revenue, then doing risk pool, then strategic purchasing. And of course, we are working together with regulator. In this case is Ministry of Health. Then Ministry of Health as the regulator to regulate, but what we are doing. And the most important here, what we are doing supported by advanced IT system. So the role of the digitalization is very important in here in Indonesia, because almost every main activities is supported by advanced IT system. And for example, with the payment channel, we working together with the bank, more than 950,000 payment channels. So everyone should pay easily, can use, for example, like GoPay, like OVO, like bank, auto debit in the bank, and so on and so forth. And the premium here, okay, here, subsidized premium for those who are poor. Then for those who are wages, they have to contribute 1% and 4% for the employer. And then for informal sector, they have to pay fixed amount of money, around $3 or $6 or $10, depend on the class they choose. Then benefit package, of course, this personal health, not public health, but personal health, consisting of promotional, preventive measure, curative measure, and rehabilitative measure. And the way for the strategic purchasing for primary healthcare, we use performance-based capitation system. And then we now already having what we call it quality transformation. Quality transformation, of course, according to the conceptual framework, is very complicated. For example, like Donapedian concept, how to use input, our structure, then process, output, and outcome. But in BPJS Kesehatan, it changed into very simple indicators, namely 3 types of indicators: easier, faster, and non-discrimination. And then to the hospital, the way we pay, as I mentioned, using INA CPGs or INA DRGs, and we have medical advisory board and cost quality control team, and also anti-fraud system. So all this use what we call it IT digitalization system. And the good thing here is that previously we have many schemes, more than 300 schemes. Every local government, like in Philippine local government units. So in Indonesia at the time, each of the district or maybe local government has their own scheme. For example, like in Yogyakarta, we have Jamkesda, up to now Jamkesta, and so on and so forth. But then merge into one single scheme. Not like in Thailand, 3 schemes, but Indonesia now only 1 scheme. And except for the private, for the commercial one. So the coverage increased so much. And the good thing is that we change from deficit, change into positive. It is the first time in the history of BPJS Kesehatan in Indonesia. Then we paid down payment. So before verification is done, we paid to the hospital already. And the payment should less than 15 days every month. After claim of the claim received by BPJS Kesehatan without pending issues and without dispute issues. Then In the year 2023, we increased tariff together with Ministry of Health, and satisfaction level is increasing. Out of pocket from 49, almost 50%, reduced to 25 or 28%, something like that. And ladies and gentlemen, so when we are talking about digital transformation, actually, we are trying to connect into four components, almost the most important component in universal health coverage system in Indonesia, namely the connection to healthcare providers. So health facilities, health organization, then number two, interconnected with our stakeholders, both central government like ministries, Ministry of Health, Ministry of Finance, Ministry of Ministry of Home Affairs, Social Affairs, and so on and so forth. Then academia, for example, like universities and so on and so forth. Number three, we connected with the bank. So here, bank and finance. Then the number four, the most important stakeholders is our members. So we connected with the members using what we call it mobile JKN. So our approach is that we should always relate to Industrial Revolution 4.0 to 5.0, including digital transformation. And we change our mindset, shifting among our stakeholders. It is not easy, of course. And literacy rate should be increased. Then innovation in various aspects. Ladies and gentlemen, of course, strategic partners, and we have many, and we have to be connected with them and using interoperability. Ladies and gentlemen, that is the number one, healthcare providers. So in the year 2014, for example, only around 2.5 billion US dollar. And now in the year 2025, more than 10 billion US dollar, more around 200 trillion rupiah, or around more than 11 billion US dollars. And the good thing is that many catastrophic expenditures, and more than of our catastrophic expenditures mostly are on heart diseases and chronic kidney disease and cirrhosis hepatitis and so on and so forth. But we around 235 trillion rupiah for catastrophic since it was established. Ladies and gentlemen, when we talk about healthcare spending or health financing in Indonesia, so total is around 606 trillion rupiah, or it is around 260 billion US dollar. So that is the total spending. And the National Health Insurance, or we call it BPJS, contributing around 27 to 30% of the total health spending. Ladies and gentlemen, this is when we are comparing JKN, Indonesian source of funding, for example. So Indonesia mostly a contribution, but for the poor, it is paid by the government through national budget. And Philippines, for example, mix between premium, also tax, and Malaysia mostly are tax, UK mostly are tax, USA mostly are contribution, and Thailand, some and HSO is tax based, but the social security scheme and also civil servant medical benefit scheme from contribution, and so on and so forth. And the good thing here that the medical doctors and also the GDP, how much contribution or health financing percentage in compared to GDP, Indonesia is around 3.3%. Philippines is quite huge, 5.6%. Thailand is 6%. And South Korea 9.3%, UK 11%. Okay. And you know, when we're talking about digital health innovation, yeah, in Indonesia mostly we have super apps, and these super apps we integrated into one system. We call it mobile JKN. So in mobile JKN, the features it can be general information, for example, like JKN program information, healthcare facilities, the nearest to our members, inpatient bed availability, mobile JKN user sign up, service history information, and new member registration, for example, registration using mobile JKN. Also, they can complain. We have the complaint submission. Also, they can connect it to the care center if something should be delivered. Also, we have member data administration, for example, like JKN digital card membership. They can print it out in the mobile JKN. And healthcare assurance, for example, online queuing system. They can queue from home, from any type. And medical care history, healthcare facility rating, so they can make a rating given so that after they receive services from hospital, it is be able to them, to the patient, to give rating. For example, give 1 star, 2 stars, 3 stars, up to 5 stars. Then medical consultation. And the good thing is now we have, for example, like video-based medical consultation. So if it is allowed, the doctor maybe ask the patient, or patient ask the doctor, mostly the doctor actually. So they can see the patient and the patient can see the doctor. But it is, of course, in certain condition, if it is allowed and with informed consent. Health risk screening. So health risk screening, it is free of charge. So everyone can download or can answer the question, around 47 questions. Then up to now, although our membership already 279 million, but only around 4 million people who are already used health risk screening in mobile JKN. Contribution payment, for example, contribution information, auto debit, payment history, virtual account information, and so on and so forth. Even today, we have what we call it, like in South Africa, they have what they call application, they call it a fatality. So if they, buy healthy food, then they can be, counted in the contribution. But Indonesia, we have what we call it not only rehab, but also we call a bugar. Bugar meaning also fatality is the same. So if we exercise how many calorie, then then the system can calculate automatically. So this is the mobile JKN users as of July. But as I mentioned, the growth trend is increasing, but still literacy rate is need to be increased. So many people do not know actually about the mobile JKN and digitalization transformation in BPJS Kesehatan, which is actually already, in my opinion, already advanced, because they are able to register, to make queue at home or any type of services. Even they can give rating, even they can complain, and many types. And then mobile JKN, we provide also simplification of administration process to be the member, to register. Then the benefit, for example, reduce administrative costs through reduced face-to-face interaction. We use also artificial intelligence in this case. So by using what we call it Frista. So our member just come to the hospital, then the hospital reader can read the member, for example, like in the immigration, using, just so they face, so the hospital reader will recognize this person actually member of BPJS or non-member. So then rehab also for those who have difficulties in paying and they have debt. or they owe the money to BPJS, then they use, we call it rehab application. So this rehab will automatically calculate how much money they would like to install, and then for how many months, and so on and so forth. And ladies and gentlemen, we have also, we call it iCare CKN. This provide information on health services history, like medical record, each of the patient. So for example, patient in Yogyakarta, maybe 1,000 kilometers away from Jakarta. So doctor in Jakarta will know exactly what type of information of health services or medical record, the diagnosis, medicine, and so on and so forth. And not only those, but this, of course, will be will convenient for doctors to find medical record of JKN members. And of course, not only those, to access healthcare facilities and healthcare services, not only iCare JKN, but we have what we call it hospital bed availability display. They can send a WhatsApp to Pandawa to ask many things, many questions. We can have electronic SIP that to go to the hospital that this patient is actually BPJS patient and should be allowed to go to the hospital, and biometric validation and online queuing system, display of surgery schedule, and so on and so forth, and teleconsultation. So, ladies and gentlemen, this is the implementation solution of online queuing system, because before we develop digital transformation on queuing system, the queue is so much, so in the hospital, so crowded. So therefore, now they can, just come when they would, about a time of services is given. And as I mentioned, iCare CKN, and we are lucky to develop this. And also teleconsultation model. We have first model, second model, and third model. First model is telehealth from participant to general practitioners. Then second model, telemedicine like tele-EKG, tele electrocardiograph, and teleconsultation from practitioner to specialist. Then the third model is teleconsultation from health worker to general practitioners. Ladies and gentlemen, of course, the first model, telehealth from participant to general practitioner, is already running. And for the video, now we are still piloting in certain clinic and hospitals. Then this is the service consultation summary, and mobile CKN teleconsultation. And not only those, we have, for example, video consultation. So they can see the person, of course, also the doctor. And second model, telemedicine from general practitioner to specialist. So if they would like to consult the result of, for example, EKG or electrocardiography, how to read or ultrasonography. So the PCare, they can consult to the specialist, something like that. And the third model from health worker to general practitioners, so they can consult also. Ladies and gentlemen, of course, there are still many things. For example, this is like telehealth and viewing the schedule, and to select a doctor, for example, filling the patient information and initial complaint, they can complain, and then the doctor can respond. And we use the, electronic participant eligibility, as I mentioned. Then we have tuberculosis patient medication monitoring through artificial intelligence, whether actually the person already administer medicine or drug or not yet. So we develop the system. This is the profile, for the hospital. So the hospital can understand or see or monitor or know claim status, claim submission, or whether still pending or dispute claim, whether still, being reviewed or still already waiting for payment, and so on and so forth. And of course, utilization of health services, for example, highest service used or case mix index, quarantine administration. And also we have monitoring commitment of the hospital. For example, refer back program. So if a chronic diseases patient already recovered in the hospital should be sent back to primary health care. And then we see online queuing system, participant complaint, and so on and so forth. So ladies and gentlemen, this is the issues on personal data protection in Society 5.0. Then of course BPJS Kesehatan, and there is a law on personal data protection, and we use ISO certification. Not only that, according to the people, we make how to certify the people and to make sure the password, the many things on the people, and we upgrade the people, and we have the tool, also policy, and also the data. For example, the data, we use it in encryption and masking and token sizing and sensitive data, so that if the data is leaked because of the hacker, then they cannot read, for example, like that. And of course, many things. And that is some, people who come to our
coming to see the command center. I found the command center also something that is remarkable. I mean, that it helps you to get a feel of what is happening on the ground, and then how it is being used also to drive enrollment and all. I think I'm highly impressed. Yeah.
So to come back to Indonesia and to see BPJS now and what it's achieved is really quite impressive. So I congratulate everyone who's worked on BPJS. It's amazing to see the level of coverage across the country and to see the attention to equity and meeting the needs of the population. And I think I'm still learning about BPJS, but what I can say is I'm impressed with how much it is innovating and testing and experimenting with new things. To me, the things that are most exciting are the things that make healthcare different for the individual. So making access easier, bringing services closer to the individual or to the community. I think the ways that BPJS is innovating and finding ways to do that, that's what impresses me most.
Impressive. So the coverage that BPJS has is something that many countries aspire to achieve. So in many ways, it's a place that we can look to learn and see what's being done here that we might be able to transfer and use in other parts of the world that are not as far along in different aspects of health. The integration between levels of the health system and from providers to BPJS is something that's really stood out. So the way that the technology has been used and information is shared to provide better care for the population is something that's been really impressive, and I'm excited to learn more about it.
I was very impressed by the digital transformation, and I can't imagine how they handled 1 million insurance claims a day. So I was very impressed by how efficient the leadership, how efficient the management of everything was.
So I think Indonesia's experience with JKN has not only been aspirational, but it's also been inspirational to a lot of countries which come from the same context, lower middle income countries that are aiming to achieve universal health coverage. The experience that Indonesia has had provides invaluable lessons to many countries that are on the same path, which Indonesia has almost achieved near universal, decreasing out-of-pocket expenditures, improving service delivery quality, as well as improving efficiency. So I think the world is looking towards Indonesia for your country experiences and how we can go back and emulate the same in our country.
BPJS keren.
BPJS Kesehatan keren.
BPJS Kesehatan keren.
I think, yeah, because of the time, so we have many, thank to God that many achievement, both in the national, regional, upon our international levels, and we have, not only reputable CEO in digital space, but also was invited in Thailand and many local and regional countries. But we also invited by UN, how actually we develop like that. And of course, again, so the digital health and AI is very, very important, both in terms of the people, process, and technology. So digital health and artificial intelligence has brought improvement in Japan healthcare insurance system by service digitalization, updated information system, and data utilization. So further collaboration and integration is essential. Of course, AeHIN, thank you very much that we can learn and work together since in the beginning, in my opinion, since 2011. And but the problem in Indonesia, some people still not aware. So you are not aware that actually BPJS Kesehatan is already provided digital transformation, and many people do not know yet because up to now still less than 50 million, using the history of screening. Because of not yet aware, then we trying to educate the people through the song. It is the last one, maybe another 2 minutes or 2.5 minutes.
I'm aware, but you don't know where. BPJS has been known everywhere. Many countries expecting to be shared. Cost, quality, control, also manage care. Many perception that is still mistaken. They think it's limited classification, only for those who are in danger. The fact that the system is in the question. Oh, you don't know much elsewhere. In the hospital, BPJS satu everywhere. To help you, and they always be prepared. So please, you need to be aware. It's technology so much impressive. Medical record at your fingertips, helping you and doctors so effective. Access anytime for one previous year. So many thought that could be misperception caused by healthcare facilities infection. Gives us not as your expectation. Let BPJS satu carry you on. Oh, BPJS doesn't have a knees. BPJS focus in other species. Our concern, access without financial hardship. I hope you put together the pieces. Even though you and your family too participated and covered, I need you. Always remember and don't forget to maintain your healthy lifestyle as you do.
Yeah, that is all. And again, salamat po. Thank you. Terima kasih. Kapurmakap.
Thank you for sharing your work in Indonesia with the AeHIN community, Pa Ghufron. Before we open the virtual floor for questions, we would like to call on Pa Anis Fuad from the AeHIN Governing Committee for a brief announcement.
Okay. Yes. Thank you, Prof. Ghufron, for sharing the Indonesian experiences on implementing digital health to support universal health coverage. Prof. Ghufron actually supported by AeHIN, the team of Indonesian AeHIN members is currently in the process to adopt the experiences of BPJS Kesehatan into one of the open source information system for universal health coverage that was developed by GIZ. So there was an application called Open EMIS. So we would like to learn from BPJS system and then compare with Open EMIS. So the process is right now we are in the beginning. Hopefully, in the next step, we would like also to consult with BPJS Kesehatan regarding adaptation of the BPJS IT system into Open EMIS system. And I think for the continuation of the discussion, there are several questions, Pak Ghufron.
Okay.
Can we discuss a little bit from
Sure.
some question from the participants? I start with, I think in the beginning, Dr. Alvin Marcelo already asked several questions. So we start first because there are too many questions, Pak Ghufron, but the time is limited. So I will not read all the questions. But Pak Ghufron, if AeHIN members also would like to ask question
Sure.
to you
Please.
and then compile by email, is it okay, Pak Ghufron? Because I think
It is
not all
okay.
question.
Yeah,
Yeah.
it is okay. No problem. We can share together, learn each other, something like that. Thank you.
Okay, okay. So I will start with the question from Dr. Alvin Marcelo. Um, the first question is regarding um, the the payment channel. There are currently 950,000 payment channel. Whether the participants of BPJS Kesehatan, when paying through this channel, they should show the ID or any mechanism to ensure the process for payment.
Yeah, for the payment is very easy because each of the mobile CKN, they have their own OTP and they have their own recognition. So suddenly, if they would like to pay, then it will not mistaken who already pay and for how long, something like that. So no worries. And the important of auto debit, because we work with the bank, auto debit, the important is in the bank account, there should be money. Otherwise, there cannot be deducted if there is empty, no money. Okay, the important thing, there should be money inside.
Okay.
And
The
thank
second
you,
question
for
from
you mentioned about the GIZ or Paul Rocket. Now, yeah, I read a direct message here. So, okay, Paul Rocket, our friend, a long time we work together. Thank you for your help.
Okay. The second question from Dr. Alvin is, in one of your slides, you mentioned that BPJS Kesehatan is working together with many stakeholders and agencies.
Yeah.
So the question is there any governance structures to make sure that all the collaboration and coordination work well? And who is the lead convener of this governance structure?
Yeah, so it's depend, and actually the government now having what they call it satu data, not satu sehat. Yeah, satu sehat is under Minister of Health. Satu data is under, we call it National Bureau Statistic, and it was it was ordered by the president directly, and in that case the one of the minister and also Minister of Planning, Bureau of Planning, they are trying to have certain type of the way to work. So when you said who is the convener, it is Minister of we call it Papenas, yeah, Minister of Planning and Budgeting, and yeah, Minister of Planning and Budgeting.
Yeah. The third question also related to the interoperability.
Yeah.
Given that you have experience in Indonesia, do you have any advice for countries, for other countries, on how to achieve interoperability between the Ministry of Health and also Health Insurance Agency? For
Yeah,
example, countries like Philippines or others.
it is very, very important. First, we should not reinventing the wheel. If somebody already, found and already developed, no need to repeat again. In my opinion, we have to talk, and then we should agree on the aim. What is the aim? Of course, all of the health system and digital transformation, the system is to accelerate. The system is to make more faster. The system is to make easier, something like that. So interoperability, the most important, there should be a unique identity number or unique things. One. So one would like to develop should talk first. So how then in the future we should interoperability? Like in Indonesia, for example, like the claim, actually Minister of Health also developed, BPJS also developed for a long time ago. So we now interoperability between BPJS Kesehatan and Minister of Health. So for example, we have e-claim and we have fee claim. E-claim is developed by Ministry of Health, but fee claim is developed by BPJS Kesehatan. But this in the hospital, no need to 2 times entering the data. Only 1 time is enough, but this can be shared together between BPJS and Ministry of Health, something like that. So the most important here should first talk first between the parties. So between Ministry of Health, between BPJS Kesehatan, or maybe in Philippines like PhilHealth Corporation, and many stakeholders should sit together and talk. Number two, of course, personal data protection is important. So there should be discussed who responsible and how to protect the cybersecurity, how to improve the cybersecurity. Then number three, there should be a unique identity number or things that could be used together, could be matched. So in that case, then they can use interoperability. I think in short, something like that. But of course, we can talk further for the detail, Pak Anies. Thank you very much.
Yeah. Okay. Thank you, Pak Ghufron. I think the last statement was also related to the question from Pak Jeff Parker. Pak Jeff was asking about the process on how BPJS Kesehatan and Satu Sehat ecosystem. What are the
Yeah.
progress right now for interoperability? Because you mentioned on e-claim and fee-claim. Is there
Sure.
any progress related to the
Yeah.
Satu Sehat and mobile CKN?
Yeah, so we work together, we use interoperability, and we launch together between BPJS and Minister of Health. So if it is needed, then I can send the picture. We launch together interoperability system between BPJS Kesehatan and Satu Sehat ecosystem, something like that.
Okay. There was also a question, Pak Ghufron, related
Yeah.
to the security from
Oh, yeah.
Fitria Ayu.
Yeah.
How about to optimize the security of all data? Because we
Yeah.
have an experience on data leakage previously.
Sure. This first, there should be a person or institution who responsible for. In Indonesia, actually, BSSN, National Security Cyber Security System, should responsible, and also Minister of Information. And we call it. We have in Indonesia like what do you call it? Wali data and the owner of the data. The owner of the data and those who responsible to manage the data, but not the owner. So like the health data, in my opinion, the owner is the patient, but the like Minister of Health or BPJS can be the, we call it, what do you call it? The manager of the data, but those who are responsible of the data. And if they transfer to a third party, to other agencies, so there should be agreement who and to whom. Yeah. So the owner have to have the right to refuse or to make okay or not okay. So the informed consent should be there. And then the levels, for example, like BPJS, we have, of course, we are not perfect, but we at least have 6 layers of cybersecurity. So I cannot mention, but the first layer, second layer, third layer, up to 6 layers. And I cannot talk one by one, but if those who are interested, then we can talk what is the first layer, what is the second layer. But almost every day, unfortunately, the hacker always try to hack every day, not only one or two more. But of course, we hope, of course, among hackers, they are learn each other and always, make, like a graduation or make smarter or make, more competent and trying to think like that. So again, we should know that. So therefore, if, for example, like ICAR as I mentioned, we should not only in terms of the data we make encryption, but in the hospital we make confine. We every day, for example, in BPJS Kesehatan, 24 hours every day should be monitored. Should be person who is responsible. They shift, for example, if something make little bit give a sign it is not okay, they should confine. And then because the data is in the encryption, should not be read, and then the password should be changed every time. Yeah. And so on and so forth. There are many things, of course, to do the cybersecurity, but as it is our experience how to do that, it is not easy, and the cost is quite huge. Not only we buying, also the application of security, maybe this developed by the hacker, but we have to buy also sometimes, something like that. Okay, there are many things.
I think we need to have another AeHIN hour specifically for some aspect on technical,
Sure.
because it is also related to the question from Ibu Atika. Bu
Oh,
Atika
yeah.
also would like to have BPJS for sharing the development and scientific and technologies, so that many students could also learn from the progress.
Sure.
Because it is
Yeah.
expected that many academia also learn from the progress from BPJS Kesehatan.
Just to let you know, Pak Anies, but before we come join to BPJS Kesehatan, it was still a little bit closed. But now we have sample data, more than 100 million data. And this can be accessed by universities, or Bu Atika mentioned student, if they would like to, analyze or would like to make something like brief policy based on the data, then we open. Although I know that some people to criticize BPJS, they use the data of BPJS. Okay, but no problem. But okay.
Yeah. Okay, Ibu Fitria, I think your question related to the opportunities for academia. BPJS have the sample data that also be open for academia for research. Cha, we still have many questions, but I think the time is running out. How is supposed to be, Cha?
For the questions that were not answered live during the session, we'll be compiling them and we'll try to send it via email to Ghufron's office, and we'll see if they have time to answer our questions, and then we'll include it in the recording that we'll share after the session.
I'd like to thank to all the participants who asked, for example, like Kevin Wu, also Titus from Nigeria, also Saraf Batarai, and many. I cannot mention one by one, but our colleague I think thank you very much for your participation, and we can, of course, we can give response.
Yes, thank you, Pa Ghufron, for proactively
Welcome.
answering our participants' questions. Also to Pa Anis for facilitating the open forum. And of course, to our participants for joining us throughout the session and for sending your questions. Before we take our group photo with Pa Ghufron, we would like to hand the virtual mic to Sir Sarav from GIZ Open Emis and Sir Paul Ruckert for a few words.
Thank you, Cha. It's a pleasure to join this session. Good evening, Dr. Mukti. It was great
Good
to listen to
evening.
you. And then
That's right.
what Pak Anis mentioned about working together with Open Emis and taking advantage of the developments that that BPJS has made and bringing it to an open source digital public good. We are very much looking forward to working together with AeHIN on that. But also, as you mentioned today, we from Open Emis, we have a special gift for Professor Mukti.
Thank you
all the
very
way from
much, and
Brazil.
welcome to verify to working together with PPJS Kesehatan.
Yep.
Thank
we have a
you very
special
much, Saurabh Patanai.
Yep. And we have a special guest for you, a special gift from you from Brazil. We have Paul Ruckert on the line.
Okay,
So maybe he can unmute and turn on his camera to say a few words. I think he has accompanied the journey with BPJS for a very long time. Paul,
yeah.
There you go.
Oh, Paul Ruckert,
Sorry.
how are you?
I'm fine, thank you.
Again.
It's a little bit dark here in this room because
we can
it's
see
in
you.
the morning here in Brazil. So my greetings from Brazil to all of you, and it's an enormous pleasure for me to see you all working together. Maybe some of you don't know that I was very much involved in the development of the health insurance scheme in Indonesia 25 years ago, a long time ago. But it's also my pleasure to see Anis, whom I think we financed your first meeting on health information systems in Jogja also many years ago. And of course, to see Saurav, with whom I used to work in Nepal for a long time. And we both were involved in developing Open Image that is now used in so many countries. So it's a real pleasure for me, especially for me, a retiree here in Brazil, that all the seeds that we could plant in the last decades are growing. And I see now huge trees. I even see forests out there. So I think it's really worth investing in development aid. I know that some countries stopped doing this, and even my own government is now considering whether it's a good investment. From my experience, I can say.
Your work as an example, it is really a good investment and better investment.
Yeah, I think so too. When I see that now millions, hundreds of millions are profiting of something that we used to plant many years ago, it's only the conclusion. Sometimes it takes some time to see the results. It's not maybe within the short lifespan of a project that you see the major progress, but you see many things after 5, 10, 20 years. So I hope that this experience, this positive experience in Indonesia and many other countries can convince politicians to continue investing in development aid and foster collaboration also between the countries. And I think this is great to see also AeHIN, one of my favorite networks. So I wish you all the best, and I hope that you will continue growing. I'm deeply impressed. Thank you very much.
So if I, be able to say something, thank you very much, Paul Ruckert. It is really very nice. And our colleague in AeHIN, if possible, just wrote a letter, please write a letter to Trump, because Trump now stopped on the WHO or USAID to help many countries and so on and so forth. In fact, it is actually, real good investment. Thank you very much. Thank you, AeHIN Secretariat. Of course, thank you, Alvin Marcelo, Pak Anies, also
Thank you,
Pak
Pak.
Surat Batarwi. Okay.